All right, please start taking your seat so that we can move on. Please, please start taking your seat so that we can move on. I know that there's some people outside of the coffee machine still, but they should move in fast. We do have people in the chat who are watching this now live, and we are recording it. So this, for your information, this is going to be a recorded session, which will then be made available for everyone to have a look before the end stage of this project. And I'm really happy to introduce this project to everyone. I'm trying to. But I know the usual suspects who are not listening. All right. So welcome to the Classic session. It's a long-awaited session because this is a project which is collaborative with Spartan, a worldwide project, as you all very well know, more than 1,000 patients included and recruited. It's about the initially possible revision of the 2009 ASAS classification criteria. And this is why we're here now, in order to see the results of this study, which has been going on both regarding the recruitment, but also the way of discussing it for a pretty long time, which I believe is also, on the one hand, also a good sign, because obviously all possibilities of how to analyze these data have been put together and taken into account. This is a long session, and you may see on the program that there is a break in between. We will shift that break to after the session. So we will have it all in one, so it's easier to discuss. And this is, I also say it for the people who are online, so that you are aware of, so they are also released a bit earlier, all right? Should you nevertheless want to go outside for a bio break or anything else, of course, everybody is allowed to do that. Again, I remind for those of you who just came in, this is being recorded. The organizational information will be also shown in a slide, some slides here after. Each part of the study, this means the ASAS representatives, the steering committee, but also the Spartan steering committee with the representatives will be presenting data here, and then we will discuss. Discuss means we have the opportunity to ask questions to both steering committee members. Intentionally, again, I let just one microphone here because otherwise it is extremely impossible to also follow everyone by the camera, because of course also the people in the chat are able to follow. They will also have the opportunity to ask questions if there are any. And we will end the session today not with a voting. That voting will take place later on this year in a common online session. And more information are to come. It's not going to be just a one-time point voting, but there will be also enough time, more than 24 hours, for everyone to vote about that. You will see some information again later on. So before moving on and giving the word to the presenters, I'd like to say a couple of words of thanks. First of all, to both steering committee members, because this was a tremendous amount of work, not just about the data, but also about the discussions, the intense discussions you've also seen partly, which at the very end have led to a really very nice result, I believe. So thank you very much for that, and it's really very appreciated what we've done for this study, for the project. The other thing is that I would like to thank Matthew Stoll, but also Jörg Ehrmann for their help with this project so far, because they have really very much contributed in the last 2.5 years or 2 years in moving forward, both in their capacity of Spartan presidents. So thank you very much for that as well. And we will move on. I will give the word to Desiree, who will have an introductory presentation. Then there is Liane, who will show the data of the study. of all the patients. Thereafter, it is Desiree again showing one of the two options that we have to vote on later, the one model, and thereafter later on for the second vote, and then there is Q&A.
Thank you, Xenophon. You're forgetting a little bit of the program, but I will explain it. There are two other sessions also scheduled. So, I don't know how to do this.
No,
there's a remote, okay. Old-fashioned. Okay, here's the introduction. So, first, I'd like to thank all the sponsors of the classic study. So the ASOS part was financially supported by the ASOS Foundation and also by UCB. And the Spartan part of the classic study was financially supported by Spartan, AbbVie, Amgen, Eli Lilly, J&J, Novartis, Pfizer, and UCB. I also like to start with a big thank you to all the classic centers that participated in the study, to the central imaging reviewers, the scientific committee members, Joel Pask for the IT infrastructure and IT support, and also the data analysis team, Alexander Cipriano, Miranda van Lunteren, and Ben van der Meer, who is a statistician from Canada and is not here. And of course, we like to acknowledge the roles of our both the PIs, Walter and Martin. So classic. We all know the 2009 ASOS classification criteria for ExPA. And we decided that we needed to give an update of those criteria. The first step was validation, and that the validation should be done in the classic study. And then we would test it for at least 75% sensitivity and at least 90% specificity. And if not met, we would modify the existing criteria. Well, we have a long session here, and you have seen results before, so we know that we are here to modify the existing criteria. So these are the criteria. This is what we are used to. And yes, there is critique about the criteria. They are too loose. The specificity is not good enough. But we also have to acknowledge that they have done a great job over the years. They have been used in many studies. They have been able to include patients in clinical trials and for the registration of all the drugs that we are using. They have all used these criteria. The aim of classification criteria is to be used in all types of research studies. We are always thinking about clinical trials, but that's not the only thing that we do. It's also about epidemiological studies, observational cohorts, and then you have the clinical trials. But that can be clinical trials for registration purposes, but also about non-pharmacological and other types of pharmacological treatment. So the classification criteria that we are modifying today should be applicable in all those settings. Also, when you not always have everything available, which would be optimal. So where are we in the process? All the ASOS and Spartan members of the Classic Steering Committee met many times over the past few years. And we had many discussions on what is the required sensitivity specificity. Is this written in stone? If you have 74% or 89%, does that mean that you do not accept it? About face validity, can, for example, imaging alone, if that's sufficient or not? How to develop, which methods to use to modify these criteria? What are the exact SPA variables? What are the definitions that we will use? What is the external standard that we use? Is it the is it the phase 4 diagnosis, phase 5 diagnosis, the central read, the local read? You will hear about these different phases of the study next by Leanne. And also a lot about the imaging that's collected in the study. We also discussed many proposals. So we have seen many modifications over the year. And today you will see the final 2 proposals that we selected. So we both have selected a preferred model, but after presentation we also say already up front that both proposals are acceptable to all Classic Steering Committee members. And it's up to the ASAS and Spartan membership to make the choice. And also, we have had all our discussions, so we'd like to hear from you. So how will we proceed? Today, we have first a general information on the Classic study by Leanne. Then I will come back and discuss the agreements between ASAS and Spartan that form the basis for both proposals. Then you will hear both proposals. And then finally, similarities and differences between the proposals. So what is it really that you have to choose between? And then then we have time for a long Q&A. So these are the timings of what I just said. So you see there's a long Q&A, and perhaps we will gain some time during the presentations. As Xenophon said, there's recording of the entire session, and this will be made available to all ASAS and Spartan members. So you can review this also later on, and people who are not here, they can also review it. In the first quarter of this year, there will be an online voting. So, and that will be organized by an independent organization, independent of ASAS, independent of Spartan. Each full member of ASAS and each associate and full member of Spartan will have 1 vote, because we have some people who are members of both ASAS and Spartan. They will still have only 1 vote. And the simple majority will decide which proposal will be the modified criteria. So what we expect today is a fair and open discussion of the scientific content. So it's really about science, about the content of the proposals. What are the similarities? What are the differences? What makes that we choose for proposal 1 or proposal 2? So now it's Leanne who will discuss the study in more detail. Oh. Okay, I see. This was not. But this was not the last one, because you asked for your other slide, your title slide. I had that.
No, it's there. I don't think so. Yeah, there. This is the title slide, right? Because you had modified this one. So thank you for giving me this opportunity. I'm going to tell you this opportunity came last week, but I'm going to present to you how we collect. I am. It's true. But my mouth is as big. So, even lower? So I'm going to present how we collected the data, the characteristics of the patients and the controls, and then testing for the validation against the 2009 criteria, and then the role of imaging. So, personal disclosure. So last week I wasn't presenting here, and actually I was on holiday with my family. We were doing safari. These are my real photographs, and you have fight or flight response when you see these big, dangerous animals. And then I got the communication that I was going to be presenting for the Spartan on behalf of the Classic study, and I reflected on this, and I thought, well, still I would rather not face off my teenage son than anything else in this multiple choice example. So I'm honored to be here to present the data to you today. on behalf of the ASUS and Spartan. So first of all, just to remind you, these are the primary study objectives. Were really to validate the performance of the 2009 criteria in this prospective global study in patients with undiagnosed back pain less than or equal to 45 years of age and for at least 3 months. And we set the pre-specified specificity of 90%. We would need to achieve at least 90% and a sensitivity of 75%. And if these were not met, then we would try to modify the criteria to meet the pre-specified cutoffs. And the focus really here is, oops, that's not on center, but it's really around specificity being the primary goal to achieve a higher specificity. So if they were not met, then the two areas that we would really focus on, one would be the MRI, really thinking about the way that variable was assessed in the study and whether we could modify the way MRI was considered to be positive or negative. And then the second part is the spondyloarthritis features and thinking about whether specific ones discriminate more between disease, axial spondyloarthritis, and nonspecific back pain, and then whether we could put weights or major minor criteria around these features, which in the 2009 criteria are not weighted. There's a list that you would choose from to add. So this is the way that the assessment for diagnosis was done. And I think you've seen this before. I'll make one point is that in Spartan, we decided to add an extra step in diagnosis, and that you can see that after the history and physical exam. And that was to really try to avoid some of the circularity that happens when you have a spondyloarthritis feature and then you diagnose someone because of that feature. So trying to see if we could think about diagnosis with confidence at each stage. And then everyone had a second assessment after labs, a third assessment after the X-ray, a fourth assessment after the local MRI, and then a fifth assessment, this is the gold standard, after the central readers and adjudication. So the rheumatologist, the site investigator, would come up with diagnosis at all of these stages, but the final diagnosis, the outcome of the study, is this gold standard diagnosis by the rheumatologist after all of these steps. This is the CRF that the radiologist saw and had to fill out. And so when they're thinking about the imaging, and in particular the MRI imaging, they were asked to determine whether they were typical, and this is a qualitative assessment of active inflammatory lesions around the sacroiliac joints, enthesial sites, and then structural lesions. And I'll highlight a little bit about what those specific lesions include. In addition, radiologists were asked, both central and local readers were asked, are the findings indicative of spondyloarthritis? So this is Gestalt. And this is really informed by the features above, the structural lesions, the inflammatory lesions. And this is the global question that was the basis for adjudication. In addition, the reader, not just the radiologist, the readers, had to assess their confidence of the radiologic diagnosis based on imaging suggestive of spondyloarthritis. And a positive MRI was determined by the local readers. So what we used in the study analysis, you will see, is the local reader assessment of the imaging. And that was in part because as we think about generalizing these criteria to real world, we won't have central readers accessible to all of us for observational studies. So it's really important that these are going to be able to perform well, not just in clinical trials, but in observational data. The local readers did not have access. They were not asked, does the MRI meet the 2016 ASUS definition of a positive MRI? So just letting you know, I will show you some data there, but that was from the central readers. We did not use this in the analysis. So these are the baseline characteristics of the patients with axial spondyloarthritis compared to the controls, or the people that were not diagnosed. Total of 1,015 patients included, and you can see that 36% of them, 36% of them were diagnosed with axial spondyloarthritis. More men were diagnosed than women, and there were more women in the control group. You can see the symptom duration is quite long, 9 to 11 years. And then I'll highlight here inflammatory back pain that was assessed in a variety of ways, including, of course, all of the individual components to meet various criteria, but also the gestalt by the clinician is, does the patient have inflammatory back pain without necessarily thinking about checking the boxes for amount of morning stiffness or nocturnal back pain. Thinking about peripheral manifestations, interestingly, and maybe not surprisingly, peripheral arthritis, a little bit more common in the patients with axial spondyloarthritis, but more tender joints in the control population. And then if you think about the EMMs, you can see that uveitis is a little bit more common in the axial spondyloarthritis population, but actually psoriasis is a little bit more common in the control population. And then no difference, sorry, let me just show you here, no difference in family history or BASMI. Finally, looking at serologic and genetic data, you can see that the CRP is a little bit more elevated in the patients, and as you might expect, HLA-B27 more prevalent in axial spondyloarthritis at 67%. Now, when we look at imaging, this is interesting. First, looking at radiography, you can see, and this maybe is not surprising to you, the local reader is always more sensitive for diagnosing modified New York positive X-rays, 38%, but also more sensitive in diagnosing modified New York criteria in the non-axial spondyloarthritis cases, or the controls. Similarly, in MRI, the local readers are more likely to call an MRI indicative of axial spondyloarthritis in the axial spondyloarthritis diagnosed patients, but also in the control population. And so what we take away from this is that the local readers are more sensitive, but less specific than the central readers are. So this 2x2 table shows you when we're capturing people that are X-ray positive by modified New York criteria, you can see actually, so 109 of the patients are both modified New York criteria and are captured in the MRI. So that's 97% of patients that have a positive X-ray are also captured in the MRI, showing us that the X-ray actually doesn't contribute that much more than the MRI does. If the X-ray is positive, almost everyone is captured on the MRI. Okay, so when we think about the gold standard, I said that was stage 5 after the central readers had their assessments with adjudication. And so this is now thinking about, did we validate? And this is the stage 5 diagnosis, first with central readers, and then I'll show you local readers. And you can see, remember, we were aiming for a 90% specificity, and you can see we don't meet it regardless of central readers, any of the central readers, and then similarly, the local readers. And as you might expect, the local readers are going to be more sensitive, less specific, and you can see it reflected in the results here. So here we do not validate. Okay, a little bit more about imaging. So first of all, on the top is the local readers, and then on the second section is the central readers. And what you can see again is that when you think about the MRI indicative of axial spondyloarthritis, of the local readers, 82% say that the patient has an MRI indicative of axial spondyloarthritis, versus the central readers are coming in at 62%, so less of them. Same with the controls. You see more local reader call, 12.1%, versus 1.7% in the central readers. Now, I said to you that the central readers were asked the question about the 2016 definition, and you can see there that 46% of patients with axial spondyloarthritis had a positive MRI. So what you can see here is that the gestalt of the MRI actually is more prevalent than the 2016 definition. This is by central readers. Central readers were not used in the analysis for the study. And then finally looking at active lesions and structural lesions, what's interesting is actually that, again, local readers call it more often, but the structural lesions are not, there's not that much difference between the local reader and the central reader's prevalence of structural lesions in the 60% for both readers. They're calling it more similarly, and in fact, the overcall comes more from the active lesions than the structural lesions. So the conclusions here are that actually, and I don't know if you remember, I showed you the X-ray positivity, modified New York criteria, was 30 to 37%. That was the sort of range, depending on whether it was the central reader or the local reader. And here you can see about 60% for MRI, so that MRI is about 2 times as sensitive as the modified New York criteria for radiographic sacroiliitis with comparable specificity. And then, as I said, structural lesions are actually, if you look at the structural lesions, so you can see 68% in the local readers compared to 59% active lesions. So you can see that actually they are more prevalent structural lesions than inflammatory lesions, regardless of whether it's the central or local readers. I know, but then I can only show it on one side. I'm so sorry. Yeah, I know. I would, if you come here, I can use it here. And then finally, local readers, as I said already, are more sensitive but less specific, especially for active lesions, less so for structural lesions. Okay, so I really like this. If you like clinical reasoning, this is a fun slide. So this is about how we diagnose patients and the confidence we have when we diagnose them. So first, if you look at the scale on the right side, you can see there's a color coding. I'm just going to do it here. At the top is red, at the bottom is blue, in between is purple. If you are +5 at the bottom, you are very confident that the patient has the diagnosis, the most confident you could be. If you are -5 at the top, you are very confident that the patient does not have axial spondyloarthritis. So as you can imagine, the more data you have, the more confident you will become. And so this first I'm showing you the Spartan data. I'll show you the ASUS data too. There was one less assessment. But you can see here, this is just after history and physical, and there's a lot of purple, not very confident at all. Then we add the labs, so the CRP and the HLA-B27. It doesn't change that much, but then you get the X-ray, and actually it's not changing that much, and it's really after the MRI, the local MRI, that you see this big jump, both in ruling out the diagnosis with more confidence, but also increasing the confidence of the diagnosis. And then after central reader adjudication, you can see that confidence goes up even more to rule it out, and there's not much change in the confidence of diagnosing or ruling in. And then this is the same data, except for the ASUS portion of the cohort, and you see there's a little less granularity because it's one less level, but you can see not much difference between clinical plus labs versus X-ray. Where you really see the differences when you add the MRI. And so what this tells us is that radiography really has less impact for a clinician's diagnosis of axial spondyloarthritis than the MRI. And rheumatologists...
Can you remind us what was the percentage of imaging negative diagnosis?
Yeah, I'm actually going to show those data at the end. There were 61 patients
Lian?
that were diagnosed with, yes.
Because the people in the Zoom cannot hear the question, can you repeat that?
Oh, yes. So you're going to ask can I remind people of the number of patients that were diagnosed with axial spondyloarthritis who had negative imaging? And I'm going to actually show the data on them, but there was 61. Yes?
It is the wrong presentation.
It is? Oh.
So no, but it will come. So if you stop now for a moment.
Sure.
They change.
It looks the same to me, but maybe I'm not there yet.
No, you're not there yet.
Uh-huh.
We saw the p-values that we took out.
Okay, the comment here is that we do need to adapt the slides to what was decided yesterday by the steering committees. There was a slight change. So far, the slides would have been the same anyway.
Yes, there's no difference.
So for everyone to be aware, there is no issue here, but we are now doing that thing. And I'm trying to find out how to solve the pointer issue, by the way.
The point issue. I'm happy to take a question.
All right, we move on. We move on.
All right, all right.
So
I
let's
love the fact
continue.
that there's so much discussion already. This is good. This is about discussion, right? This is not about me presenting data. It's about me presenting what we have for us to discuss. Okay, so finally, the point really here is that rheumatologists do not have high confidence in their diagnosis until they have the MRI, both to rule in or to rule out. So the primary MRI variable, I don't want to say outcome variable because this is not the outcome is the gold standard diagnosis, but the primary imaging variable is the MRI is indicative of axial spondyloarthritis, yes or no? Okay, that is how we're going to define MRI for the purpose of the analysis. And the local RITA imaging data was used for testing in the models. So that's what you're going to see today from both Desiree and Liron. So just to re-emphasize, MRI structural lesions are actually more prevalent than active lesions. And they enhance sensitivity with very little impact on specificity. And then as I've shown already, the pre-specified cutoffs were not achieved trying to validate using the 2016 definition, but that was only by central readers, not for the purpose of the analysis. All right, you saw this from Torsten earlier. This is just to make the point that this is the acquisition protocol that was used in 100% of the Spartan patients and most of the ASA sites. So the 4 sequences necessary include a T1 and STIR semicoronal, a STIR axial, and then an erosion-sensitive sequence. And that really the MRI indicative, that this variable for MRI was informed by all of these sequences, including both active and structural lesions. And I would say that's one of the big lessons we've learned just in the last 10 years is how important structural lesions are as we're thinking about diagnosing patients. We didn't have that in the past. So this is a consensus agreement as to, MRI indicative of axial spondyloarthritis feels like a very vague assessment. And so this is what was used to think about this assessment. It really is ASIS-defined inflammatory lesions, and you can see those include typical things of inflammation, and then structural lesions, similarly including the structural lesions that we think about around the sacroiliac joints. All right. So now let's look a little bit at reliability and thinking about when, first with radiography, and this is the overall cohort, and you can see that the best kappa you can get, and this is between the local and the central RITA, is a kappa of 0.5. And what I'm going to show you is that's probably the best we will ever do. We're not going to improve precision or reliability on an X-ray, in part because we're not going to improve the way we perform X-rays or the quality of an X-ray, a radiograph, and in part because I hope that as we continue to diagnose patients in the future, we will diagnose people earlier in the course, and because of that, we're going to have less radiographic damage, and that will actually decrease the reliability. People disagree more. So this is the point that that reliability is actually not very good for X-rays. Let's.
Lian, sorry to interrupt you.
Yes.
No, wait until the slide was over.
Want me to go back?
One thing I would like to say is you're all allowed to take pictures if you're doing that, since this is an.
Don't put it on Twitter yet, though.
Exactly, but please do not share anything from this data in any social media.
Yeah.
Right.
Okay. So now, I said to you, I think we can't do any better. So this is actually, if you were wondering, well, what percent of the people meeting modified New York criteria, this 30 to 38%, if you look at the breakdown, this is by local reader or central reader, you can see that actually the majority of patients meeting modified New York criteria are doing it based on a grade 3 or 4 score. So these are not patients, the minority of patients actually had bilateral grade 2 to meet the criteria. And so that you can tell this is actually quite an advanced radiographic group of the patients meeting modified New York criteria. We are not going to do better than this. Now let me show you MRI data. So I don't have the composite for the whole cohort. I have the Spartan data and the ASUS data separately. So I'm showing you the Spartan data, the ASUS kappas on the bottom. They're very similar. So this is first the MRI indicative of axial spondyloarthritis, and you can see this kappa is much better. So actually much more agreement on the MRIs, regardless of whether it's local central reader or central and central reader. And you can see the kappa I've got circled is central reader 1 and central reader 2. Similarly, the kappas look like this for the ASUS readers too. And this is in comparison to the radiographic kappas of 0.5. Okay, now this is looking at the active lesions. And you can see there the kappa is 0.64, so also reasonable, better than the radiographic kappas. And for the structural lesions, you can see even a better kappa. So you can see for the MRI data, you get much more reliability across readers, whether it's structural lesions, inflammatory lesions, or the overall assessment of a positive MRI. Yes.
Hold on, sorry. We are not allowed to get any questions to that, please. We do that later.
Okay. I'm just following direction.
And I'm following agreements, so...
All right. So this is, now if we think about, well, do MRI and X-ray contribute differently to thinking about the diagnosis and the weighting that is relevant? And so the two approaches that we use Lasso, and you'll hear more from Desiree in terms of the multivariate model that was used from the ASUS side, but the Lasso coefficients, which are data-driven coefficients from the way that the rheumatologist is assessing the patient, you can see that the weight is significantly higher for MRI than it is for X-ray. And actually, that is very similarly shown using the multivariate model. You can see that the odds are 10.9 for the X-ray and 72 for the MRI. So this suggests to us that MRI is really contributing significantly more than X-ray. We were talking about, Jürgen asked about the imaging negative population, and so this is looking at a histogram of the confidence diagnosing patients that have negative imaging. And remember, the negative imaging is negative imaging of the sacroiliac joints. And you can see that less than 15% of these patients diagnosed, there were 61 of them, diagnosed with axial spondyloarthritis with negative imaging. There was less than 15% that we were really confident about, if you think about confidence being 4 or 5. So that the level of confidence in imaging negative patients is quite low when you do not make high confidence diagnoses. And so then this is the demographics of this population. So there were 61 of them, and this is going to help when we talk about the models. This is important, so it's just seeing what these patients look like, and the point here is that of these 61 patients with negative imaging, only 30% of them were HLA-B27 positive. You can see the rest of the features there that I'm not going to go into detail, but these are people that we should be really pausing as we think about, do they really have the diagnosis, and certainly would we want to classify them? All right, I think, whoops, that brings me, to my conclusion slide, so last slide. So first of all, in the classic cohort, the 2009 criteria were not validated based on our pre-specified cutoffs of 75-90% sensitivity specificity with a plan for revision. You'll see that after this. MRI is the dominant feature for the diagnosis, and that is regardless of setting, whether it's central reader or local reader, and what this is really informed by both active and structural lesions. And that is new compared to what we had before. And then the rheumatologists with expertise in axial spondyloarthritis, that's many of you that were investigators, do not weigh radiographs and MRIs equivalently. That's it. Thank you.
Try to put it a bit higher again. Okay, now it's really in my face in front of the slide. So these are the data that we had to work with. And then now I will show you the agreements that we achieved to further work on. So when we develop models, we do that in a testing data set. So the data set was split randomly in two. We have a testing data set, and only the selected models in the end, when we say, okay, these are the models that we want to continue with, then we test those in the validation set. And those are the important data to show, because that's really what you need, and we will not show the performance in the entire data set, because you have used the testing data to develop. Phase 5 diagnosis is the reference for testing the criteria performance. You heard that already before. We present the performance for the central readers after adjudication, and also for each central reader separately, and for the local reader. So the local reader is where we want to have the 75 and 90% sensitivity specificity, but we show the performance in all the different reading sessions too. And this is what I just mentioned. So we strive for 75% sensitivity and 90% specificity, and specificity is the most important. Then we also agreed that this would be the stem for the criteria. Patients with a diagnosis of axial spondyloarthritis, mimics excluded, plus a history of chronic back pain of at least 3 months, and the age at onset before 45 years. So it is, in fact, what we in principle had for the existing criteria, but we did not really specify it as this. So now it will be the top of the model. For all the SPA features, they are included as current or past. And I think that makes especially Maxime happy, because there was always a big debate about IBP present. And if past, it should be documented previously by a rheumatologist. And then also important, the final revised models will be both presented in a table format and a tree format. So we are used to the tree format. That's what we have with the existing criteria. To the left here for you. And to the right, I just took the RA criteria, which is in a table format. So that has nothing to do with the content, just the layout. You can have tree format, we will have tree format, we will have table format for both the proposals that you will see today. We also decided that the global question, because we had many for the MRI, but the global question, are the findings on the MRI, and it is of the SI joints, I added that, indicative of spondyloarthritis, will be used as the MRI variable. And this includes both active and structural MRI lesions. We also agreed that there is no mandatory central reading in the modified classification criteria. And also that imaging alone cannot be sufficient for the fulfillment of the criteria. You have already seen some data on the regression analysis, and you could easily say, just take an imaging MRI and that's it. But we decided that cannot be the case. Also, it cannot be the case that you are both imaging negative and HLA-B27 negative. Also, those cases cannot be classified. Then we also think that we have put together a very nice data set that can be used later also for all different projects for both established and junior investigators, including trainees. Then the variables. So these are the variables, the way we have used them in developing the models. And also, so in the end, when one of those variables is included in the model, it's this definition. For inflammatory back pain, if it's the clinician, it's the past or current IBP according to the rheumatologist's global opinion, ascertained by rheumatologists at the time of evaluating the patient. If we talk about NSAID response, is what we were used to, 24 to 48 hours after full dose of an NSAID, the back pain is not present anymore or is much better. Family history, this is limited to present in the first-degree relatives of any of the following: axSpA, psoriasis, uveitis, reactive arthritis, or IBD. Peripheral arthritis, past or current active synovitis, ascertained on physical examination by a rheumatologist at the time of evaluating the patient. Heel enthesitis, again, past or current, presence of enthesial tenderness at the site of insertion of the Achilles tendon or plantar fascia at the calcaneus, ascertained on physical examination by rheumatologists at the time of evaluating the patient. So you recognize the same part of the sentence, always starting with past occurrence, and also ascertained, blah, blah, blah. And also dactylitis, the same definition. Then we have the extramusculoskeletal manifestations, acute anterior uveitis, the past or present confirmed by an ophthalmologist, and this is an ophthalmologist because that's the only one who can really make that diagnosis. For IBD, it can be a physician, because if you also have the information, for example, from a biopsy, then also another physician could make that diagnosis, and the same for psoriasis. Then B27, just positive testing according to the standard laboratory techniques. Elevated CRP means a CRP above 5 milligrams per liter in the presence of back pain. So it can be also in the past, but it should be in a period that the patient also had back pain. Then sacroiliitis on imaging means an MRI indicative of axial SpA. You have seen this definition already by Liane. So it's ASAS defined inflammatory and or structural lesions, assessed simultaneously by contextual review of all recommended sequences by at least one reader with expertise in axSpA imaging. And those abnormalities are highly suggestive of axSpA in terms of both their location in the SI joint and also the extent. And it's mostly that those two types are there together. Then on the radiographs, that was no change with what we are used to, fulfilling of the modified New York criteria, so either bilateral grade 2 to 4 or unilateral grade 3 to 4 sacroiliitis. So these are the definitions that we are working with. And now I will present proposal 1. So now it's the time where you really have been waiting for.
Can we make a short discussion here before the proposal?
That's up to the chair.
No, we would leave the discussion for afterwards, because then you have a full picture of what's happening.
So proposal 1. That was started the development from the existing 2009 ASAS criteria. The idea is you modify criteria, so you start with what you have. And it was made sure that this was applicable both in a tree and a table format. So although the existing criteria is a tree format, it should also be available in a table format. The tree format still gives good insight in the implicit weighting of the variable. So if you have a stem, that already gives some extra weight, and you also know in which route a patient is fulfilling the criteria. And it also gives you easily information which combinations are not allowed, because you cannot have imaging alone. You cannot have imaging and B27 negative if you follow the tree format. The choices that were made in the development of Proposal 1 was mostly influenced by phase validity and also by information obtained from regression analysis. This is a regression analysis. You see 4 different analyses. The first one is the ASAS 2009 validation cohort. So that's the old cohort, and that's where we had only activity on MRI. We had the modified New York criteria, and there we used the IBP ASAS definition. Then if you go, and this was based on local readers. That was the only thing we had at that moment. If you go to the right 3 models, that's in the classic cohort, and that's, then we use the data from the central readers. The first model is where we have the radiographs and an active inflammation on MRI together. Here you see that radiographs, so an equivalent of structural changes, have the most weight. And if we then go to another model where we do not have the radiographs for structural damage, but we use the structural damage on MRI and the active inflammation on MRI separately, again you see that the structural damage is giving most weight to the model. And if we then go to the last one, where you have the MRI global definition, so where we have in one definition both active and structural lesions, that's the highest contribution. But still, the structural damage only seen on radiographs, it's not out. So it's still there, it's still contributing information. What you can also see, if you look at that impressive 72, it's an enormous wide confidence interval. It ranges from 32 to 162. And if you look at the radiographs, it's also a very wide confidence interval from 1.6 to 73. And then this is the imaging part. Then we go to the next one, that's IBP. And you see, as we will use the last column, where we have the global definition of MRI, that's our definition of the imaging. It's also to that right column that you have to look for the clinical variables. And then you see that there is a high odds ratio for IBP clinicians. And what's followed by B27 and by IBD. So what were the conclusions from these analyses? Radiographs are still important to assess structural changes. It's not taken everything by MRI. The global MRI, including the active and structural lesions, is the strongest predictor, but does not capture it all. And then looking at the agreement, there is no debate that the agreement for radiographs is worse than the agreement for MRI. We know that all, and that's also what we see in this study. if you look, though, at the absolute agreement is 89% for the radiographs. And if you look only to those cases where one of the two central readers, and we're talking here about the best option, the two central readers, if there's one of the two says it's abnormal, there's in 59% of the cases, the other one does not agree. So we say, then the conclusion is radiographs are really bad. But what about MRI? I think that's also not what we are hoping for, because also here the absolute agreement is 90%, so 1% more. But also here, if you have, in 34% of the cases, if one reader is saying this is abnormal, then the other one does not agree. So also in 1 of 3 patients. So kappas are extremely nice for groups, but we are not talking about groups here. This is for individual patients, and then this is important information. So the conclusions is that IBP is the strongest predictor after imaging. That's indeed true if you look to the model to the far right. But there's also a disadvantage of IBP, as there is large disagreement on using different definitions. So in the model, we used IBP clinician. But if you look at the classic data, then according to the clinician, it's 73% of the patients have IBP. But if you look to other definitions, for example, ASA's definition, it's 64%. Kalin definition, 49%. Berlin, 58%. And that means that 14% of the patients are captured by at least one of the other 3 definitions, is not captured by the definition by the clinician. And 31% of the patients not fulfilling any of the other 3 definitions is captured by the clinician. So the data is not important, but just to know that IBP is not written in stone. It's not that you know this patient has IBP, then I can completely be sure that this patient has IBP. And also, if we do the same analysis, now not using IBP clinician, but IBP, the ASA's definition, you also see that that odds ratio drops from 8.6 to 2.3. Then the only other significant predictors are HLA-B27 and IBD. So for the matter of phase validity, we started with keeping all the different SPA features to develop proposal 1. And then giving different weights inspired by the information from the regression model, also what we know about these features, we came up with a cutoff of 9 points, and then you have sacroiliitis on imaging that can either be the global MRI definition or fulfilling modified New York criteria is 6 points, and you need at least 3 additional points. That's one arm. The other arm is based on HLA-B27, which gets 3 points, and then you need at least 6 additional points. And you see that IBP, uveitis, IBD, and peripheral arthritis, so the IBP who came out as highest, and the other, there are also objective measures, they all get 2, and then the remaining SPA features get 1. These are the data in the validation data set. So if you look at the last line, which is the local reader phase 5 diagnosis, the sensitivity is 79% and the specificity is 89%. Then it was thought that perhaps we can further refine this model, not using all SPA features. And the NSAID response was removed because in XPA patients, 33% of the cases had a positive response, and in non-XPA it was 22%. Dactylitis overall was very rare, and also the family history, we know from other data that as soon as you have information on HLA-B27, then the information on family history does not add much. So then we took out those 3 SPA features, and then the sensitivity in that data set was 7. Oh, and you're not taking pictures of me, but only that's me. So then the sensitivity is 76.9, and the specificity is 90.7%. So then the decision was that this should be proposal 1. Proposal 1 in the tree format, what you are used to. We also know that HLA-B20 does not count twice when you have it in the stem at the right. But you have exactly the same information. You can also present it as a table format. So if you like this more, you use a table format, exact same information, exact same sensitivity and specificity. So then if we compare proposal 1 with existing ASAS criteria, what's new? Well, the MRI variable now has active and structural changes combined in one. We have excluded 3 less specific SPA features. They are no longer part of the criteria. It's available in a tree and a table format. The preset sensitivity and specificity has been met. And when do you fulfill the criteria? If you are imaging positive and HLA-B27 positive. If you are imaging positive and have at least 2 SPA features, before that was only 1, so I had imaging and only 1 SPA feature. And then if you are HLA-B27 positive and you have at least 3 SPA features, before it was 2 SPA features. So also you can easily see that these were more restrictive, so aiming at the higher specificity that we had with the existing criteria. So what are the advantages of this proposal? It elaborates on the well-known 2009 criteria. It still closely resembles the gestalt of axial SPA. There is especially focus on the clinical characteristics. The item weighting is largely based on the regression models. It's stricter than 2009 criteria. And also, if you think about if there would be new imaging methods, let's think we want to use CT. Then it's easy if you have the same weight for radiographs and for MRI, because then you can also for the CT, then you use the same weighting. So with positive imaging, you still need 2 clinical features, and it can be easily implemented in all different settings. So also, if you do not have MRI available, because in your study you have only radiographs, then it can still be used easily. So then I give the floor to proposal 2.
Jeroen?
Okay, I'm just setting the timer to see how far I run over. Yeah, okay, yeah, so
All
Leanne
good.
was kind enough to donate 3 minutes.
We have enough time, that's all good.
We have enough, yeah, and of course Desiree ran perfectly on time, exactly, so Before I begin, I just wanted to say we had the pleasure of dining with Robert and Desiree last night, and obviously the topic of the 30 years came up, and it was just such a pleasure to see her face light up knowing that it was coming back to her hometown. And I'm just really grateful that we had that opportunity and that we all really owe her a great debt of gratitude. Primarily for being part of the formation of this organization, which has evolved into something so wonderful, and then now as a host in her own hometown. And so thank you, Desiree, I want to say. Okay, and then I also wanted to thank Walter, who gave us the first draft of these slides. So I am Ron Kaplan, and I'm going to skip over this because we've made some changes there. So the first point I'd like to make is, as I introduce Proposal 2, is around the ACR and ULAR classification criteria format. And this format occurs in a table and has occurred in a table since the publication of the 2009 criteria for all of the jointly sponsored ACR and ULAR classification criteria. And the principle... Oh, the Zoom is not hearing me. Okay, this is the first time someone has not heard me. Okay. Okay, if only my kids could hear this. All right, so every classification criteria that has been jointly sponsored by ACR and ULAR's relied on this because of its simplicity. And the basic principle here, which I'm going to be focusing on, is that each of these individual items has weights, and then we'll talk about the cutoffs. Since the last time this slide was shown a year ago, we see that the juvenile SBA criteria have been added to the list. This is just an example here from the GPA criteria about how these weighted criteria, this is the last part of in blue, the weighted criteria can improve the measurement performance because certain items within the criteria may be more discriminative. And so we're going to be focusing on that, and also the question on how we arrive at the different weights. So that's about the format, and now I'd like to talk about the general approach to developing classification criteria, which begins with item generation, then moves on to item reduction, so reducing the individual features that you're considering in your criteria. Then weighting of those items and setting a threshold, that's synonymous with determining the cutoff. So when we say setting the threshold, that's what we're talking about. And then finally, validation. And as Desiree mentioned, the item generation, all of the features that we considered were all derived from the 2009 criteria. And then we used a variety of techniques to narrow that down to get the classification criteria as simple as possible. And that included different regression approaches, as well as using some expert opinion or face validity, however you want to refer to it. And there was some difference between the development of the two models in terms of the approach, the regression approaches to item reduction. So the approach that was used for Proposal 1 was, and this was again introduced last year, LASSO, which is the least absolute shrinkage and selection operator regression. And so this sounds maybe a little bit overwhelming, a little bit intimidating because it's maybe used in AI, this procedure. But basically what LASSO does is simply use math to describe the actual behavior of the investigators. And what I mean by that is the investigators in the study by themselves said this patient either classifies in as a typical case of axial SBA or is not. Say again? Did I misspeak? Diagnose, okay, yeah, sorry. And then all that LASSO does is tell you what the clinical features were that are associated with that diagnosis, okay? And so it's essentially just feeding back to you the behavior of the investigators according to the decisions that they made, not what they said was important, what their concept of axial SBA was. It's actually just the mathematical equivalent of what they did. So it explains which variables should be included, but it also is able to contribute by identifying those variables that should not be included and thereby producing the most efficient, the simplest model. It explains the relative importance of the individual variables. So if one feature showed up twice as often as another in folks that were diagnosed, then that person would have a double weighting, for example, conceptually anyway. And then it avoids overfitting. So overfitting is a problem that occurs when you develop a model in one population and then you try to apply it later on to a different population. And if the model is so well formulated on one population, it may not work well in another population. So lasso as a technique buttresses against that as a possibility. And so it does lead to more generalizability and increases the likelihood that whatever model we develop is also going to work elsewhere. So the first step here, and just to, so this is going to be highly abbreviated. Obviously, there's a question as to what we were doing for 2 years in the analysis, but this is going to be highly abbreviated. So there were many, many steps, which I'm not going to include, but I'm going to include a couple just for illustration. And so the first thing that we did was include all of the features and looked at what the lasso regression told us were associated with the diagnosis of axial SPA versus not. And when we did that, these were the coefficients here in the middle column. Now they're not whole numbers, which makes them a little bit difficult to use. So we simply just multiplied it. And it turns out that just the multiplier in this case that gives us integers, gives us whole numbers, is 20. And so we ended up with the figures here to the right, which lets you know the relative importance, the weight assigned to each of these. And as Leanne pointed out, you can see MRI dominates this model. It's at the top, radiographic sacroiliitis second from the bottom. So this was a little bit problematic because it does, you know, for any cutoff that's 14 or below, it means that all you needed was the MRI. And that's a problematic way to implement the classification criteria. It gives us an incredible amount of specificity, approaching 100%. I think the actual number was something like 98 or 99%. So what we really were looking at, in essence, is how do we identify the folks in which the MRI is negative? And so we performed another regression that in those without the imaging data to try to figure out what the relative weights were of the non-imaging variables, and that produced the weights here. And so in the imaging negative group, this allows us to determine the relative importance of these variables. There were a number of steps at this stage that we took with further regression. And we also did use some element of face validity. There was a concern for the reason that was pointed out before, that only 3% of the population had dactylitis, and that with such a low prevalence there, what were we sacrificing if we were including that? And so based on further lasso regression and based on also expert opinion, we decided to include CRP and psoriasis. And so that did inform our decision making. And that allowed us to arrive at this proposal number 2, which has the same stem of the back pain and the age in folks that are already diagnosed with axial SPA in order to determine whether they classify for studies. You can see the imaging and genetic portion of it, 8 points for MRI, 7 points for X-ray, HLA-B27 4, and then in the clinical criteria, this is really easy. You don't have to remember if something is 3, 2, or 1. It's basically inflammatory back pain's 3, everything else is 1. And so that's how simple that component of it works. So I've just now shown you the regression coefficients and how we convert it to the weights. And I want to also point out on that previous slide that you could see that MRI was 8 and 7. And you may ask yourself, well, why 8 and 7? So the model worked really well when we used 8, but we really felt that X-ray also did not contribute as much. Now, if we as MRI. So if we look whether we did it by logistic regression here, as is on the left side, or by the lasso, which is on the right side, you can see that there's a huge difference in the MRI and the radiographic weighting. And so technically, if we wanted to stick just to the mathematics, you could argue that the MRI is 7 times more important than the X-ray, or here it's 14 times more important. But, okay, and those are now highlighted in two different ways. But we felt like the minimum that we could show, because there was some disagreement over whether there should be different weighting for X-ray and MRI, the minimum that we could do is assign them at least 1 point different. And it turns out that the model behaves very, very well when we do even that. Again, to reiterate what Leanne said, the big difference in the shape between people who are very confident that a patient does not have the diagnosis in red or blue, whether they have the diagnosis, that big shift in the distribution, all these uncertain purples shift to the side when you add local MRI, and then even more so with the inclusion of the central data. And this is the data for Spartan. Leanne showed it to you for X-ray. There's also some precedent for doing this with the juvenile SPONDI guidelines, which were published just this past year, where in the scoring for negative X-ray is 0, for X-ray is negative imaging is 0, for X-ray is 13, and for MRI is 23. So there's, huge differences in weighting applied to these two different imaging modalities. And that makes sense to us also based on face validity, right? When you think about the MRI, you've got, if nothing else, 4 different sources of information here that are feeding into your decision-making as opposed to one with the X-ray. And so it makes sense that it's providing us more just conceptually, apart from just how the math is working out. Okay, let's talk about the cutoffs here. And really, the cutoffs, you vary the cutoffs in order to achieve some endpoint. And we determined ahead of time, a priori, that we wanted 75 and 90 because specificity was more concerning. This slide, basically, the most important thing, again, is just that we had a predefined target of 75, 90. And so you can vary that cutoff to hit the target. So with this proposal, it turns out that a cutoff of 11 allows us to hit that 75, 90. It also, even though conceptually we made the arguments that you shouldn't have negative imaging and negative HLA-B27 as a case, and also that we should have at least one clinical parameter, it turns out that even though that was conceptually something that we had to come to an agreement, what this tells us is the investigators were doing that anyway. The math just simply works out that you cannot get the 11 points without including a clinical variable, and you can't get it with imaging and HLA-B27, where if you just have those two, it's 8 and 4. Sorry, it's 11 for a cutoff, right? So really, the math is that if you add up all of the clinical, all of these, it adds up to 9. So you're never going to get the threshold. And so essentially, the way the investigators were behaving basically informed our decision, or matched up with our decision to be strict about the requirement for clinical characteristics. And then last, we did validation. And so what I've done here on top is I've highlighted the performance in the testing cohort and the validation cohort for sensitivity and specificity. And this was the agreed upon parameter that we would use, or standard rather, that we would use for the performance of those, both for, this is proposal 2 over here, and then this is proposal 1. And you can just compare there, and you can see how we meet the 75, 90 cutoff for both of those groups. So one of the goals of, I think, one of the goals of the proposal 1 was to try to identify some of the folks that were negative imaging. And so this demonstrates exactly what's happening with the true positives and false positives there. So 61 of the patients were diagnosed with axial SPA, but without imaging positivity. And so with proposal 1, you do capture 3 additional folks with, that are considered true positives using that model. And that is at the cost of false positives, including 7 additional false positives. And so, not surprisingly, you see a slight decline in the accuracy because of this approach. Okay. And then lastly, you can point out, you can include both the tree format here as well as the table format that I showed you before. So the sacroiliitis on imaging could be for MRI and the X-ray. This gets a little bit complicated with all the different permutations, and Desiree is going to go through all of those, and so you're going to see all of that, but it is possible. When it comes to the actual features themselves, very easy to remember. 3 for inflammatory back pain, 1 for everything else, as I mentioned to you before. So the advantages here, we achieved the 75% sensitivity and specificity for both testing and the validation data sets in accordance with the protocol. And then we include features based on the decisions of the clinicians here. So the lasso mathematically tells us how investigators behave, and in that sense, the model is driven by the data. We don't need to guess how the weighted items were translated from logistic regression and where these weights are, and whether they were arbitrary. We have incorporated some elements of face validity. We make it more likely that the results are generalizable to other cohorts by simplifying the model, and then there's less questions about, HLA-B27 appearing in one of the branches, and then also in the clinical, which for everyone here is probably not a problem, but for people who are not as sophisticated, that may be a source of error. And then lastly, and most importantly perhaps, it acknowledges that X-ray and MRI, while both important, are not equivalent. So it extends the weighting, that same concept that you have used everywhere else in the model, independently to the X-ray and to the MRI. Thank you.
Thanks, Liron. So we will conclude this with a small presentation about similarities between the two proposals before we move on to the discussion.
So you have seen the 2 proposals. So you have seen the development, but now in the end, we have 2 proposals. So where are they the same? Where are they different? So where should you focus on to make a decision which one of the 2 you prefer? So let's start with the similarities. Same imaging definitions. So it's MRI is exactly the same, active and structure changes, radiographs modified New York. Same SPA features even, with the same definitions. So also no difference between the 2 proposals. Also in both of them, if you have imaging, doesn't matter if it's MRI or radiographs, plus HLA-B27, you fulfill the criteria. And they both reach the predefined sensitivity and specificity. So the difference is really in the weighting of the criteria, and then which combinations will you get? Because this is what we derive in the classic study. But we will go out and apply it to other studies, to other patient groups. So what are differences between the 2 proposals? Proposal 1 has a tree format very similar to the existing criteria. Proposal 2 is a bit more complicated because you have the different weighting of the imaging and the clinical features. If for proposal 1, you need in the table format some additional wording, that it cannot be that you are imaging negative and HLA-B27 negative. For proposal 2, that's not needed. And proposal 1 has the same weight for MRI and radiographs. Proposal 2 has more weight for the MRI. And also then there is different weighting for the SPA features. So proposal 2, IBP is 3, all others 1. Proposal 1, it's IBP, IBD, uveitis and peripheral arthritis have 2, and the others have 1. But how does that now turn out in using it? So that's what I try to make different scenarios. What are the ways of fulfilling the criteria? For proposal 1, if you have MRI, and at least two SPA features, then you always fulfill the criteria. The same is true for proposal 2, MRI and at least two SPA features, but it can also be with only IBP. So if you have MRI and IBP, sufficient. Then assume that you are MRI positive, but you don't have IBP, you are HLA-B27 negative, then you can still fulfill proposal 1 with at least two SPA features. In proposal 2, then you need to have 3 SPA features. In the situation where you have radiography and IBP, in proposal 1, you need 1 additional SPA feature. Same for proposal 2. So if you have IBP, then it doesn't matter if the radiographs are positive. But if you don't have IBP and you are not B27 positive, then in proposal 1, it's still positive radiographs plus at least 2 SPA features. But in proposal 2, if you have modified New York criteria positive, you need at least 4 SPA features. And for proposal 1, HLA-B27 and imaging negative, you need 3 SPA features. But in proposal 2, you can only fulfill it if you have IBP, and then an additional 4 SPA features. And just to repeat, imaging and HLA-B27 positive is the same for both proposals. You will get a handout. So I think this is the time for the handout, where you have both proposals. On one side, you have the tree and table format of proposal 1. On the other side, you have the tree and table format of proposal 2. So I think it's easy to have this available during the discussion so that you can look at the proposals.
All right. So these proposals have now been given to you in hard copy in case you would like to make comments. These proposals have been given to you in case you would like to make comments. And there is the possibility to ask questions to both proposals. We do have more than an hour to have Q&A. So if that is, so please stay quiet for a second and listen to the instructions of this discussion. So there is one microphone, and this is intentionally given because otherwise we cannot show the person who is asking the question to the Zoom. Everybody can participate, but please only by microphone, all right? There will be people on the stage, Liron and Desiree, who have presented the proposals, who can take up your questions. And otherwise, there is also microphones to be given to the steering committee members if there is any question directly for them, which you can, of course, also guide Liron and Desiree, so you can come up. All right. One thing I would like to mention up front, and this is extremely important to me, there is no ASAS and classic proposal here. So ASAS and Spartan proposal. There is two proposals derived by the classic dataset, which we do need to vote upon, and I kindly ask you to keep that in mind when it comes to possibly also other arguments beyond that. There is a clear agreement between the two steering committees, which I do very much appreciate, that those two proposals are really equally good, depending on how they perform. It's about what we prefer now to have as a community, and this includes the Spartan people who, again, either are online or will listen to this presentation. So please go ahead. Anybody who wants to have a question, please stand on the line. There is no questions allowed from the floor otherwise.
Ms. Irene van der Horst, thank you very much for this nice presentation. I was wondering why the weighing of the extra-articular manifestations was almost equal, as we know that anterior uveitis occurs much more often than the other extra-articular manifestations. That's not weighing more, that doesn't seem to have the same weight.
If you looked also at the baseline data, there it was a little bit more with uveitis, but not very much more. And this turned out to be the best way to weigh the features.
I would say that was probably a surprise to us too. We expected it to be a little bit more weighted, but in the end, this was based on how the individuals diagnose the patients on their own, and so that association wasn't as strong as we expected, but that's what the data showed.
Before we move on, also please state your name when you're speaking so that people in the Zoom can follow it better, because it's the camera is not always easily switching.
Hi, my name is Marina Magre. I'm from
Closer to the mic.
Cleveland, Ohio. Thank you for the great presentation. I have a question. The Lasso regression you mentioned about giving weightage to the criteria was based on some mathematical modeling, and that's how the weight was given. How was this done for the multiple logistic regression, the weights for each of the criteria?
It was not directly based on the weights, but the weights of the regression analysis were giving direction to which variables weighted more. And we tried many different weightings during the process, just as also for proposal 2, you are seeing the final result, but we have seen many proposals for both of them in between.
Marina, please come closer to the mic.
HLA-B27 arm, we will only use the HLA-B27 weight once, which is 3 points in the main.
Exactly, just like the existing criteria, and that's also on the bottom, that you only use that once, yes.
Thank you.
Phil Mees from Seattle. These are comments not directed at the models, but instead about the wording of the items. So you indicated that like a past diagnosis of uveitis or IBD had to be done by a rheumatologist. Could they not be done by their respective specialist instead?
IBP. So
Please repeat that.
inflammatory back pain needed to be.
No, I'm sorry, IBD.
So that's by a physician. Yeah. So
It's by a
so
physician.
for IBP, it needs to be that's inflammatory back pain. It needs to be a rheumatologist. But for the other ones, it could be other specialists. Uveitis had to be by an ophthalmologist.
I misread one of your statements then. The other is, this is more of an American issue, and that is increasingly the staffing of rheumatology offices is being done by nurse practitioners and physician assistants. And so I'm wondering if you could potentially use the phrase rheumatology clinician instead of rheumatologist to acknowledge that this is an increasing phenomenon.
So
I think the only place that rheumatologist appears actually is IBP, and so to be more inclusive, I think we could include that, right?
No. I don't think there is any rheumatologist. It's physician. So that's what probably you mean. Instead of physician, you
Clinician,
should say clinician, yeah.
Correct.
But there is physician in two places, for IBD and for
I,
psoriasis.
yes, that's true.
Physician, but no, there is no rheumatologist. But yeah,
I think it'd be
fair.
fairly easy to just change that to clinician.
Yeah.
And whenever you use the phrase rheumatologist, say rheumatology clinician.
Can we please keep it central? It's very hard to stand here and try to listen to the question and have all people speaking around you.
So kind, so very kind. Thank you. Elena, Mark Ortega, Bilbao Leeds, Assas, Pritzbach, Rapa. Okay, so 2 questions. If I understand correctly, obviously, this is still a classification criteria, and it's a revision of the classification criteria. The 2 proposals are very different on the core stem at the top. So proposal number 1 is referring to individuals in which a diagnosis, a clinical diagnosis of axial spondyloarthritis has been made, and then you apply the criteria. Is that correct?
It's both the same.
No, they are not. They are different.
But then there's a mistake because they should be exactly the same.
Okay, so then this is my question. If they're different, why are they different?
They are
And
not
what would be
different.
okay, so here they are. So the final wording should be the one
you
that
bring
is
this?
relating to proposal 1, right?
Can I
No,
have one copy, please?
they're the same. There's no difference.
Well, I'm really sorry. Maybe that my glasses need adjusting.
Yeah.
I am right. I am right. Thank you. Okay, so then can you correct me and confirm that the correct wording should be the one referring to proposal 1?
That's the one. That's the one.
Okay, so then,
Proposal 1 is the correct one
Okay.
that was agreed upon.
so then that is extremely important, and it's going to be a long way, go a long way to utilize and facilitate the implementation of these criteria, because it will become completely clear-cut that the diagnosis is clinical and the criteria is going to aid the classification of the patient. So that is an extremely important, so thank you for that. That was my question.
All right.
And then the second one is,
Helena, may I ask you? So please keep this otherwise quiet. It is indeed extremely difficult to follow what is being said, even in front of me, if there's a lot of background noise. So if you want to discuss something, please come up to the microphone. Otherwise, it's really
Okay.
distracting a little bit over here.
So we've established the wording, so that's really important, so thank you for that. And my second question is, I can't remember from the study, where was spinal MRI acquired, as well as the sacroiliac joint MRI?
No,
No.
there's no
Okay.
spinal MRI, just sacroiliac joint.
That's fine. Okay, well, thank you.
So before we move on, Jürgen, there's another question that came up in the Zoom before you were there. So may I read it out? It's from Matt Stoll. I will read it out. In the univariate analysis, it says, psoriasis was a negative predictor. How did it end up as a feature in both models? Is this entirely phase validity, or does it perform better in multivariate or lasso models than in univariate?
It's phase validity.
Yeah, this is indeed phase validity, to keep all extramuscular manifestations in the classification criteria. And it did not matter really if you took psoriasis in or out, did not influence the performance of the criteria. But if you would have just followed the analysis, then it would have been out. And we thought that would be very strange if you think about XPA, that psoriasis would no longer be in.
There was almost certainly a lot of channeling bias in this study that was a little bit artificial, because we were looking specifically for axial SBA as opposed to just a rheumatology practice. And so the folks that came to us, there were tremendous numbers of folks with psoriasis, and it just so happens that most of the people with psoriasis and back pain still don't have axial SBA. That's not to say that in the general population that folks are that it's not a risk factor, and so that was some difficulty that we had to negotiate.
Jürgen.
Jürgen Braun, Germany. I have 3 points. Even though, Desiree, you mentioned that radiography has a value on its own, I think within the next 5 years, nobody will talk about radiographs of the SI joints anymore. So that is one argument why I wouldn't support to have it looked at it separately. So it's imaging. The other point is if we make the pointing too complicated, and we have experience from the AMO criteria, who also were a bit complicated with different numbers, and they were really good criteria, but they were never used. So that is one argument. And the other one is a probably more important comment. And when we developed the first ASAS classification criteria, we were really trying to focus on a group without imaging. So in this study, what I learned is once you have structural changes, you are certain with the diagnosis and with the classification. There is no more problem. So what I would like to see is an analysis of the group that has no definite imaging in terms of structural changes. And I'm not sure whether this group is large enough to really make a point that we can diagnose. And I'm not talking about this group, what we see here. So we have patients who are have 9 years of symptoms. So this is not early disease. And I'm not sure how this performs in early disease. And this is what I really would like to see. And this has been a problem in all the NR-AxSpA studies.
Jürgen, you make it complicated.
Sorry.
Let's try to start from the beginning, where you said that in 5 years' time you will no longer use radiographs. That may very well be. I think even now, if you think about clinical trials in countries who can spend a lot of money. But we want to make sure that these can be applied all over the world and also in all types of studies. I think, therefore, the radiographs are still important, and they are also in both proposals are there. The only difference is in the weighting. But in both, if you have structure changes, and that's part of your second comment, if you have structure changes on radiographs in both proposals, you need at least 2 additional SPA features. So in the end, the performance is not really different. Only when you're also IBP negative, then you really see a difference. So yes, I agree, this was not early disease. And yes, I agree, if you have structural changes, then it's done. But we also decided that could not be the only feature, that you need to have also the clinical feature.
I think we need good criteria for this group that has no structural changes. And I'm not sure we have enough patients in this study.
Sorry, so just so I understand your question correctly, when you say we need analysis in folks without structural changes, you mean you want to see an analysis in folks with inflammatory lesions or that were MRI negative
No
or
structural
X-ray
changes.
negative? Yeah, we didn't do that. What we did was we looked at folks that without the imaging, but we didn't segregate it by structural changes or inflammatory. So I guess we can, a 61st model. For a different publication.
University of Toronto, Canada. So I had the same question as Helena, but I didn't hear your answer. So what can you specify? Like, is there a difference between the two?
No, the stem is identical. So if there's a difference in the stem,
which part is identical?
the entire stem, and that's the one that I showed on the slides,
So
and that's with the mimics, excluding mimics.
No, so
That's
you
proposal
mean that a patient
one.
has to have a diagnosis of spondyloarthritis?
Yes, so proposal 1 has the correct stem. But that should be also on proposal 2, so there is no difference between the 2 proposals with respect to the stem.
But I would have thought that if you're doing classification criteria, you really don't care about the diagnosis. What you want to do is can you
You
classify a
start
patient?
always in patients with a diagnosis. That was the big issue we had with the existing criteria, that they were used to make a diagnosis. And then you have a low pre-test probability, and if you then apply the criteria, then you still have a low post-test probability. So, and exactly because we try to prevent that with the new criteria, we have had this, we added this STEM.
So you mean to tell me that all the patients that participated in the classic trial were diagnosed as spondyloarthritis by the physicians?
Yeah, it was 36%. So we had controls, we had folks that weren't, and it ended up being, for the overall study, 36%. In fact, of the 1,015. Yeah, in fact, we had talked about when we illustrate this, really, regardless of whether we're talking about proposal 1 or 2, having a box, a separate box that says, first make the diagnosis, and some other classification criteria have done this already. First make the diagnosis, and then the arrow into the classification criteria.
So that's interesting because most of the other sets of criteria do not have the diagnosis in the STEM.
They should.
That's
They
correct,
do.
but still they should be applied in patients with a diagnosis. That's for all classification criteria. Leanne, you want, Walter has the microphone.
So I think, so when we think about classifying an individual patient, the diagnosis has to come first. But it is true that we apply classification criteria in epidemiologic studies where you don't have a diagnosis for population level
But, so you won't be able to
research.
apply these criteria
Yes,
to
but the point is when
population
you're
studies,
trying to
and you
apply
wanted
it to an
have everywhere.
individual patient, first the diagnosis.
Can I
So
also
that was my issue, because
Yeah.
if you want to apply it to all kinds of studies, you may have a problem. The other point that I wanted to make, which is not a question, it's more of a suggestion, is that we're going to be voting, sort of based on our own opinion kind of thing, but I just wonder whether it's not worthwhile using another cohort to actually test those two proposals.
That's definitely going to happen, but this was a $4 million endeavor, so maybe not tomorrow.
Martin has a comment.
Yeah, Daphne, just to extend on that.
Daphne?
If you look at the ACR-EULAR criteria for rheumatoid arthritis, there's a stem saying the synovitis not better explained by another disease. In other words, a patient with a diagnosis of rheumatoid arthritis. And also with the new vasculitis criteria, ANCA-associated vasculitis, it says patients with a diagnosis of vasculitis. So they all have the diagnosis of vasculitis.
The CRP2, it's not explained by...
Okay, John.
Yes, John Ravel.
I like to comment first to what was said before about the validation. We will not easily get another 1,000 patient cohort, but we have existing cohorts, and they are also in earlier disease. So yes, these proposals can be applied in those cohorts. But doing so would again delay the process. I think we have quite good information, what are differences, what are similarity to base your choice on.
Okay, John Ravel, Houston, Texas, and Petbury, Thailand. First of all, I just want to say what a wonderful study this is, what great presentations these have been. Such an important study for the future, and how honored, completely honored I feel having been at least a small part of this. So I brought this up before, and I'll say it again because I have a lot more data. I am concerned about excluding patients from being classified as axial SpA who are B27 negative and imaging negative. When we look at areas around the world where the disease frequency of axial SpA of B27 is very low, such as in African Americans, 60%, Latin America, 70%, Sub-Saharan Africa, very low, the Middle East, like Lebanon, 40%, and conversely, psoriatic spondylitis overall, which only has a 40% frequency of HLA-B27. And then conversely, we get the situation where we have a high population frequency of a non-SPA-associated B27 subtype, such as Southeast Asia. I mean, this is a lot of the world we're talking about here. And to exclude these on the basis of being B27 and imaging negative is of great concern to me.
It's, you can never have everything. And to really have a high specificity of this magnitude, which is really a high specificity, compromises had to be made, and you have to make
Well, they weren't
choices
studied,
in
and
it.
there's like, we're talking 2 to 3 billion people here. So, you know, it's a lot of people.
And there was, and it's also good that we have data from centers all over the world. So it was not based in only Western European, North American centers. We have included patients
But
from
African
all over the world.
Americans, Africans, Sub-Saharan Africans.
No, we are sorry, we cannot serve everyone.
Yes.
We have to bear in mind that we're going to be using these classification criteria to recruit patients for clinical trials. So how comfortable are you going to be putting a patient on an experimental therapeutic with a potential for toxicity if you're both B27 and imaging negative? So they've got to fit for all the different scenarios where we use the criteria.
What do they have, John? If they have back pain, but they don't?
If they're B27
Please speak in the microphone because the people cannot listen to you, and the Spartan colleagues will also need to know your information.
Well, they can hear me without a microphone usually.
No,
If they're B27 negative and imaging negative is a concern in many populations around this planet where there's a low disease frequency of HLA B27, like Lebanon, 40% example. You know, this is in Kuwait.
Can I comment? John, I take your, I'm sitting here, Martin Rutverleit. I take your point regarding HLA-B27 positivity. There are differences around the world. But I disagree with the imaging negative because we both don't know what is the precise disease in patients who are negative on imaging, no structural changes, no inflammatory changes, and B27 negative. I don't believe they have XLSPA, maybe some other people do, but the truth is none of us really knows. So it's better to leave these patients out.
I see them and I know.
My name is Basil. I'm coming from Egypt, and I have two broad comments I would like to address. One of them is that are we minimally changing the current criteria so as improving the specificity, etc., or exploding the criteria and then generating a new one? With all respect to the efforts and the data, etc., I'm just thinking of the credibility of the SS and the criteria, while keeping in mind we have this criteria and then we added some numeric to the same criteria and then we increase the specificity, etc., or just change it everything and try to put it again. This is one concern to me, is that to keep the credibility of what was going on for 15 years, doing studies on that, etc. And then I'm just thinking, what are we going to call the criteria? Is it modified assess criteria for, modified assess Spartan criteria for, okay? This is one issue.
So I will take that up because this has been a matter of discussion also between myself and the Spartan president. This is the revision of the ASAS classification criteria. The naming of it will then be discussed among all people who have been involved primarily. So we do have criteria that are now being revised. These are the old ones, or the 2009, they're not over. Needed revision based on the specificity increase, and this is what was happened there. So I now take the word and say, yes, we do increase even the credibility by improving the classification criteria. And this goes to both of you, and you yourself and John. It's not about not allowing people getting treatment, right? Because it was also said that we may exclude people from treatment. This is not the case. This is for studies that are based on such criteria. Diagnosis is different, and the diagnostic recommendations or the treatment recommendations include diagnosis, not classification. But regarding the naming, this will be the next step. This is the revision of the ASAS classification criteria of 2009.
Okay, my second point is about the, as Desiree just said, you can't have everything, but I think we need the criteria to be generalizable and with great amount of equity, so it can be fit for everyone. I was just thinking of my own patients who are unfortunately B27 negative, most of them, despite that they're having positive family history, and not only the first relative as suggested here, but also second relative. I have many patients. A grandfather has psoriasis, for example, and the grandchildren has axial SPA also. But anyway, those patients are B27 negative, have inflammatory back pain, have high CRP, and they can have late or not very easily accessible to MRI, but more easily accessible to radiographic. And then if I apply proposal 1 and proposal 2, I was just thinking, and this is a way of the criteria, but if we have also positive family history, that could be easily applied to classify them. But anyway, proposal 1 and proposal 2, if you have inflammatory back pain, imaging in the x-rays and a high CRP can fit the 9 points here and the 11 points here. So both proposals are the same. So to me, if I would choose between the two proposals, I prefer to keep the old one, but just doing the numerics and exiting or deleting, removing the older one, rather than changing the whole picture of the criteria, because this is my own impression, and it can be also generalizable. Thank you.
Okay, thank you. Anna Molto from Paris. I would like to thank you for this great presentation and to congratulate everyone to managing to present us 2 proposals. I just wanted to ask whether I understood correctly for proposal 2, that actually a patient with a positive MRI and IBP alone could then fulfill the classification criteria? Well, that as a clinician who get a lot of referrals for AxSpA diagnosis is a concern to me, because if we keep in mind the setting of the study, even the local reading of the MRI was in very high expert centers. So, of course, we've seen that the central reading is more specific, but still you don't have like usual random reading of the MRIs. So if we are aiming for more specific criteria, I think that's the main goal of this project. Now, with proposal 2, if I understood correctly, we are giving more weight to a clinical symptom. To me, that's okay. But in terms of specificity, I'm concerned on how specific this symptom is in a setting in which we do know we will not have every time super experts reading imaging. So that's just my concern.
Well, why would you be more concerned about radiologists reviewing MRI scans as opposed to radiographs? I mean, I would have more concerns about the radiograph than the MRI
it's
scan.
The same. My question is about giving more weight to IBP and imaging alone, whether it's MRI or X-rays. I think. Yeah, but maybe I didn't do the calculation correctly.
You're right. No, X-ray 7, IBP.
Because and I find it as a clinician much more specific, but then I didn't do the calculation, so I don't know if I have chronic back pain and uveitis. I don't know. It's just my opinion as a clinician, and I wonder how IBP went up so high in proposal 2.
Atul? Data are the data, and even in the proposal 1, IBP came up as pretty high, if you look at that. So both proposal 1 and proposal 2, inflammatory back pain by clinician came up really high. And with only MRI and IBP, which is what you're concerned about, in somebody starting the back pain before the age of 45, that is in the stem, when the diagnosis is made, you actually are looking at the specificity. You're looking at the specificity of 91%.
Yeah.
So okay, please stop. Sorry, Atul, really excuse me. Just for better clarity, please keep the discussions either at lower level.
It's really tricky to hear.
Or do not do them right now, please, back there. Otherwise, we cannot listen what's said. All right.
I'm just saying that with that, the specificity is 91%. So data are the data. And so one example may be different, but this is in 1,000 people both proposal 1 and proposal 2, inflammatory back pain, did achieve pretty good weight.
Yeah, so indeed, in this classic data set, that works very well, but your concern is more when I apply it to a different data set.
Yes, in the patient that I might get to include in clinical trials later on.
Yeah.
Thank
This,
you.
one way to think of this is that the models that we developed were the collective behavior of 75 roughly, or maybe 100 axial SPA experts around the world. So that's as good as we can do right now. It also, in terms of the question that was brought before with the lack of HLA-B27 in other populations, that's a legitimate concern. But this study is not going to fix creating a biomarker when none exists. It's just based on the science that we have.
I mean, you mentioned channeling bias before, and maybe that's all the IBP performances that you get here. Maybe is also reflecting the skills of the clinician, including patients in the trial.
Probably, yeah, probably. I think,
One comment on the IBP, your assessment of IBP as an investigator in the study was blinded to everything else. Besides
everything.
Besides the history and physical exam, because that assessment, at least from the Spartan side, was done without finding out what the B27 was or the CRP. So,
but IBP doesn't change with CRP. When you assess IBP,
your impression, your overall impression of whether someone has inflammatory back pain may be theoretically influenced if you know the patient has a high CRP.
Not the IBP to me, but that's my clinical.
But the other thing, Anna, just in terms of like thinking about enrolling these patients in clinical trials, there will always be a central reader for clinical trials.
There will always be
a central reader for clinical trials.
Cohorts, not always.
That's not
for epidemiology. No, not every.
But that's only for pharma trials, and the classification criteria are for everything.
Before we move on, please keep it quiet. Thank you.
So, Maxime de Gallas from Paris. I have one comment concerning the classic study and one proposal for the presentation. The comment from the classic study is just to emphasize the difficulty we have when elaborating criteria to select the control group. And I anticipate that you will have a lot of, you need to be prepared to answer to the reviewer. Explain me the baseline characteristic of the control group, because if my recollection is fine with 12% of psoriasis, sub B27 in more than 20% of the case, that is, you have to be, you have started the answer, Lian. But my question concerning this control group, the odds ratio for psoriasis, if my recollection is correct, there was more psoriasis in the control group than in the spondyloarthritis group. And I don't understand at the end why you have a odds ratio over 1. I was expecting to see an odds ratio below 1. That's my comment. It's a minor comment concerning...
No. I think it's important to understand. So what you're saying is that, in fact, we developed the criteria in the most difficult situation.
Yeah.
So where your patients are referred because of a suspicion of the disease, so that means because of they have some SPA features, and still they do not get diagnosed. So this is the most difficult situation. With psoriasis, that's probably one of the reasons why they were referred and why they had the question, is this actual SPA? So we overruled the data. So yes, if you would have a purely data-driven outcome, then it would have been a negative odds rate, so a negative point if you would have psoriasis. But we said this does not make sense. That does not belong to the gestalt of actual SPA. So we keep psoriasis in. And then if you test it with and without psoriasis, that has no impact on the performance.
I do understand this, the way you have selected psoriasis, and I agree with that. But I am just discussing the statistical analysis you performed, the classic study showing an odds ratio above 1, suggesting that there is more psoriasis in the spondyloarthritis group. And why not I was expecting an odds ratio of 0.8 or point something, but not above 1.
So
but that's
this is, yeah. Yeah, this is what I was going to say. Is this is also a simplification because there are obviously a lot of interactions that are happening here, and there were definitely models that I can't speak to for proposal 1, but there were definitely models in the model 2 in the development where psoriasis was significant, although it was very, very weak. Okay. And so there were, I don't mean to suggest that was, this is why I said, you know, I'm showing you, you know, the first lasso regression and then the second one, and then skip through 58, and then we have the end, because there were some models where it was significant, and we do think there were some interaction terms.
But that's okay, that's a detail. Now I have a proposal concerning the presentation, in what you call the STEM, that is in which population these criteria have to be applied. Just to remember, that we made a mistake when we have elaborated the ACR-EULAR criteria for rheumatoid arthritis. Most of the people are looking at the table with the weighting system, and most of them forget that finally, if you have synovitis plus a typical erosion on the X-ray, it's enough. But nobody is referring to this, because it is in the sentence, in the body of the text. So my suggestion is that to be sure that you are, I don't want to come back to the discussion with concerning whether or not you should have the diagnosis or not, but I like the proposal in the proposal 2 where it is included, the STEM is included in the format, in the tree format, that is, it is written plus. You see, meaning that it's mandatory to fulfill this one. Otherwise, you are not allowed to continue. So, and I think that it's a main thing.
That's a good suggestion, and that can be done.
The plus is very important for me,
yes.
because when I read it, okay, I am not allowed to continue if these two conditions are not fulfilled.
That's a good suggestion and can be applied to both proposals. Yeah.
Congratulations, first of all. I admire all the work that has been done by the team. I have a question. You might be not too surprised that it deals with family history. That feature, clinical feature, is not in the criteria anymore, in contrast to acute anterior uveitis. Both family history and uveitis are highly associated with HLA-B27. A person who is B27 positive and has anterior uveitis has a higher risk. A person in the general population who is B27 positive have a risk of a few %, but in contrast, if the family history is positive, the risk is about a factor 10 higher. So, have you any comment on that?
Yes, this was also a matter of trying if you add it or not. But the background to take it out was that in other data sets where we use family history, then if you have no information on B27, then family history is more or less predicting a higher risk of having the disease. But as soon as you know HLA-B27, then it does not really add extra information. That was the reason, and I think in the lasso it did not come up, but...
Yeah, we found the same thing, that investigators, when they were diagnosing folks, once they had the HLA-B27 status of the individual patient, that they no longer considered family history.
Yeah, that's what I understand, but does that not the same apply to acute anterior uveitis? Was that still in?
Yeah.
I understand the principle. That's also linked to HLA-B27, but not in the same way. It's so it's that's still contributed in the model. So when you add uveitis, it does change the model.
Okay, thank you.
I have two comments. Liron, you gave me a copy, black and white, and on this side of the audience, they had color. and you know, I'm an artist as well. Just looking at two sides, what Desiree has given me looks beautiful. And I may be tempted to vote for beauty.
You should not be surprised.
While on this side, I think the North American, my friends, they should have aligned the items to the left, the way Desiree has done. I don't know why you have centered them. They don't look nice. And my proposal is that you reprint with the changing that kind of looks, and also print it in color rather than black and white, because some of the items on black and white are difficult to read. The other point.
Yeah, but Asim, to be fair, we had color prints, but it turned out they were not enough, and then they had to make black and white prints. But I think we don't need to worry about the layout. That will be made beautiful in the end for each proposal.
Well, it may affect the voting, but anyhow.
Well, okay, then take that into account.
The other point, you have to say something.
I was going to say Proposal 2 is firmly left justified, pro-left justification. So it's centralized.
The
but
other thing, what Philip Meese has pointed out, that instead of physician, it could be physician-clinician. There is a potential problem. If the study was done where uveitis was recognized as diagnosed by ophthalmologist, inflammatory bowel disease was considered present if it was diagnosed by gastroenterologist, and then the other items were recognized.
So in the CRF, it was uveitis had to be diagnosed by an ophthalmologist, and both IBD and psoriasis could be diagnosed by a physician. So that was the way it was in the CRF.
So if my friend Philip Mee's suggestion, physician assistants are not physicians. Their level of training is not equal. So if you are going to change that definition, it may impact the usefulness of your study. And so that's an important point. I think we should stick with what clinicians were utilized to select those items rather than try to make that change. If that change is needed, it should be data-based. And the last comment, I will be willing to mediate between Walter and John to resolve the HLA B27 issue, because I think I know a little bit about this entity of B27. Thank you.
Thank you, Asim.
One question or one comment by in the chat, if I may read that before Uta speaks. So this also comes from Matt Stoll. I read it out. Were there any differences in the design of the study that resulted in the 2009 classification criteria, in the design of the classic that would have accounted for the different results? Or is it mostly the assessment of structural changes in the MRI? I repeat, were there any differences in the design of the study that resulted to the 2009 criteria and the design of classic that would account for the results, for the differences?
Yeah, I think that's, I think due to two different things, that having structural damage on MRI and using central reading, I think those are the two differences with the development of the original criteria.
Also imaging in everyone.
And imaging in everyone, Liron is saying, and that's definitely true. In the first cohort, we did not have imaging in everyone, so that was also a limitation then. Yeah.
Walter, you want to add something? I can repeat that. Can we check that microphone?
I just wanted to comment on the imaging. The imaging has advanced, the MRI technology has advanced. So we now have 4-sequence imaging. This is done routinely in most SPA centers around the world. And so we have advanced imaging, and I think that's very important I mean, what's the message we want to send to the rest of the world?
It was about the specific things that were used in the study.
Yes, and that was advanced imaging. We had erosion-sensitive sequences and a standardized approach to the imaging.
Yeah, and also most likely more centers at 3 Tesla, and in the previous one, 1.5.
All right. Thank you, Uta.
Uta Kilz from Germany. So thank you very much for all the speakers. I really appreciate the clarity of the presentation. Before coming to my question, I would like to ask you to homogenize the definitions, because also on proposal 2, it's written that enthesitis, current, inhales are the definition of the variables. So I think it's needed to check that. And
Be sure that that will really be the same for both proposals. So don't not penalize one of the proposals. That will be exactly the same.
Okay, yeah. Then I didn't really understand how you come up with the different thresholds, either the 9 or the 11 thresholds. So did you apply different tests to select them? I might have missed them, but did you present the different test characteristics of that, or is that too far of this
I
initiative here? Because
I think that no one of you wants to see everything that we did. So it's yes. There were many steps in between before we came to this final proposal.
But to answer your question specifically, we look at cutoff, at a cutoff of 4, 5, 6, 7, and then we, as a result of that, that produces a sensitivity and a specificity, and we just look at all of them, sort of like area under the curve. Like, except that we weren't using area under the curve because that blends both the sensitivity and specificity, and we wanted a higher emphasis on specificity. So we picked one that got us closest to or above 75, 90.
And then the two proposals were chosen each proposal was then chosen by, let's say, each group in terms of presentation based on their best fit of sensitivity and specificity of choice.
And I recognize that the variables included in the two proposals are the same. So, but for one, it's the 9 and the other is the 11 threshold. I understand that the calculation of the sum score is very different, but would it make sense to also provide the sensitivity and specificity data for the 9 cutoff for the proposal 1 and the 11 for the
No, I don't think that those are two completely different proposals in that sense. So it's a combination of the weighting and the cutoff for each proposal, and that is one. You cannot just start separated and start adding other cutoffs for the other proposal. That will both make them worse. And in the end, you will not see the other one because we choose one, and then that's the cutoff.
There have been other classification criteria efforts where they have given exactly what you're talking about, a table in the supplement where they show so that if you wanted higher sensitivity or specificity, but we didn't want that degree of complexity, but it's possible to do that.
Okay, thank you.
Thank you. Mikkel Østergaard, Copenhagen, Denmark. First, a quick comment that is around this worry about inflammatory back pain plus MRI or plus MRI X-rays, if that's enough. And then I would echo what Atul said, that it's not only that, it's also that you need to have the diagnosis, you need to have back pain of a certain length, and you need to have the age below 45. So I think it's not only that. And then if it was just from scratch, then I would also be worried. But anyway, my real comment is that first of all, I'm really happy with having, you could say, data, because I like that you base your criteria on data. I think that's great. And when I then looked at the data, I think both by the regression analysis and also by the Lasso method, it came out that MRI was a very, very, very strong predictor, or whatever the word is, and much higher than X-ray. And then you could say I was, kind of surprised that the weighting was in one proposal equal and in another one quite close to equal. You could say the imaging is higher in proposal 2 compared to the other methods because it's 7 and 8, and the other is 3, 2, 1. And the other is 3. So it's more separated, the imaging, from the clinical parameters there. But that was one thing. And now I know it's data-driven, but I think that you also mentioned that there was, you could say, some face validity. And I think we know from studies done in Berlin, for instance, excellent studies where you compare MRI, CT, and X-rays with each other and show that MRI also for structural changes is closer to, much closer to the gold standard of CT than X-rays is. And then it makes me even with face validity coming in, I think it's surprising that they are so close, and particularly that they are equal. But that's just a comment, because I would think that it would be logical that it was, you could say, weighted higher based on that. So that is probably my main, and then I think that proposal 2 is closer to that, but I'm actually surprised that it's not even higher difference. Thank you.
Well, so it turns, do you want to answer this one?
Yeah. So what I'd like to say is there are some additional analyses that are informative, but the decision to give a weighting of 7 to radiography and just a little bit less than MRI was really based on the face validity consideration and the fact that there would be centers around the world without access to MRI. But in fact, if you look at the data, you can reduce the weight of the radiograph to 6, 5, 4. You can eliminate radiographs completely with little change in sensitivity or specificity. In fact, if anything, the specificity improves a little. You can completely remove radiographs and you'll still get 75, 90. So MRI is capturing everything that the radiograph shows. And in fact, as you know, I mean, what is the lesion on radiograph? What is the axPAR related lesion on a radiograph that you cannot see on an MRI? What is the lesion? I'd ask anyone in the audience to tell me what lesion you see in a radiograph that you cannot see on an MRI. I'd be interested to hear the comments of the musculoskeletal radiologists.
Walter, I don't think that that's the discussion. We are not debating that. That's just no, but because sometimes you don't have an MRI. That's the issue. And I think you can even make a more bold than you already did. You need only an MRI, not even a single clinical SPA feature, and then you have a specificity of close to 100%, 98%. But that's not how we want to do it. And also, we have now the clear stem that you have to make a diagnosis first, but we know that it will be used in a different way, and that it will be used to just make the diagnosis. And then those aspects also play all a role.
But I fully understand this with that you can't have MRI anywhere, and that's a good reason for having it in with some weight. And but could you somehow in the paper or in a subtext in a table or something say that the main reason for being in there is not because you expect to see anything in X-ray that you wouldn't see in MRI, but rather that it's because the criteria should be valid everywhere, not only as for instance the fact with what was mentioned before about it.
Yeah, as Leon says, we didn't start writing yet, but you have seen across table that most of the information was kept by MRI from the radiographs, but you also have seen in the multivariate analysis that not everything was kept. So still, radiographs had the second highest odds ratio after MRI before other clinical features. But that will all be addressed in the paper, yes.
Rob.
Thank you, Rob Lambert, Edmonton, Canada, and it's purely coincidental that I have stood up after Walter. Mikkel has already made many of the points I was going to make. But the point I want to emphasize was that we have included, and I think appropriately so, psoriasis on the clinical side purely on the basis of face validity. And I think that to equally weight X-ray and MRI based on both the data and face validity would be incorrect. Both the external information we have would indicate that MRI is the superior test, and the multivariate analysis, which was based on local reader interpretation of the MRI. So it's not based on...
No, that was on Central. That was Central Reader. Yeah, I'm sure.
But I don't think it'll be very different if you did it on
Okay, but it was on Central. What you have seen was on Central.
Okay, I'll accept that. But we agree that the odds ratio is very different based on the multivariate analysis. And the external validity would suggest that the two should not be weighted equally. But I totally agree that both should be included in whatever model we select.
Yeah, but if you look in the end to how it then performs, it's the same if you have radiograph positive in model proposal 1 or proposal 2, you need 2 additional SPA features.
No, I understand what you're saying, but it is also true that we know that these criteria, as you just said in response to Mikkel, that they're now going to be applied outside of the setting that we're expecting. And therefore we have to be careful implying that the 2 imaging studies have equal weight, when in fact we know they don't.
So yes, we will have radiographs outside all the experts, and we will have MRI outside all the experts. So that those concerns apply to both.
Right, but one model implies that both imaging studies have equal importance, and I don't believe that that is true. And I think the external validity, face validity, and the odds ratios indicate that.
Yeah, but then you also get to equity. If in parts of the world you cannot do an MRI, then you need to have extra things because of that.
Right, so then what you're asking is, between the 2 models, which have equal sensitivity and specificity, is there are going to be different patients that are included or excluded. So there'll be some patients that are a little bit different. And there was a table put up which showed that with the different patients included with the different models, they're not identical. And therefore, which would be the safer of the 2 is a question which is not easy to answer.
Yeah, and so the equity issue is extremely important, but it cuts both ways, right? I don't think we do our patients, any benefit if we're enrolling them for a disease and exposing them potentially to a therapy that they have very little chance of responding to due to misclassification. That's I think just as abusive. So yeah, absolutely, we want to include people from trials, but we also don't want to include people inappropriately.
Final comment on the radiographs. You have to keep in mind that this study was the most challenging population because they had suspected axial SPA. If you apply the criteria to patients with established long-standing disease, radiographs will be more often positive. You are more confident in interpreting radiographs appropriately. And if you would do regression analysis in such a population, the result may be slightly different from what we have seen. So this is my comment on that.
Can I comment? So quickly, I completely agree with Rob that if you look at it from data-driven point of view or face validity point of view, the MRI or X-ray should be weighted less or lower, and that's why the proposal 2 is different, because we agree that face validity is more for MRI, as well as data-driven approach also showed there is much more weight to the in the both regression analysis or lasso.
Yeah, but then you have the issue that if you start applying the MRI outside the known people, then it's only IBP which is needed as an extra feature. And if you think about clinical trials, where you have the exposure to drugs, that's where you always have the central reading, and then that's covered.
The issue there, though, is that you're getting so much more information from the MRI. I mean, we have to look forward.
But I'm not debating the usefulness of the MRI.
Okay,
if the MRI is positive, if all you've got is radiography, what are you going to weight equally? Radiography, inflammatory back pain, and another SPA variable, or a 4-sequence MRI with both inflammatory and structural lesions at the same time? And we're looking at advances in MRI where the MRI can look like a CT scan. So we're getting phenomenal information from an MRI that radiography does not even touch.
We would need
but
to move on
you
because
may-
this is really indeed going beyond the discussion, I believe.
I just
Please.
want to, people are struggling with IBP, but this is surprising to me because the modified New York classification criteria only required grade 2 bilateral sacroiliitis and IBP. And we have accepted those for clinical trials for years.
Yeah, but no longer.
We are
And
improving
that's
the
exactly why
situation,
you want to improve it. And that's also why in Proposal 1 you have imaging plus always at least 2 SPA features.
Well, it's not 2 SPA features if they're each weighted 1 in Proposal 1.
Okay, this is
Because that's
exactly
6 plus
the
2 is
reason,
8.
Leanne. This is exactly the
So
reason what.
at least, so it may be even more strict. Not just IBP, but at least 2, it may be even 3. That's exactly what I tried to say. We are more strict than
as
the
an
modified
English
New York.
speaker, my interpretation of at least 2 is not that it may need to be more than that, because it's about the number of criteria, and not all criteria are weighted equally.
Okay, we need to move on, also in the interest of time.
Excuse me, Mr. Chairman, can I make one nuancing,
Short, please, yeah.
very brief nuancing remark with a statistical background? I think I would like to remind those who are listening to this that we are not testing against the truth. We are testing it against the aggregated opinion of all of you here in the audience with all different opinions about what axial SPA really is. The second remark is that when you look at MRI being far better than radiographs, please keep in your mind that we always see the best figures for MRI appearing at the moment that radiographs are also tested. I think Desiree showed one model in which MRI was excluded, and then you get an awfully high odds ratio for radiographs only. Obviously, we don't do that in the presence of MRI, but the performance of radiographs should always be seen in the context of the fact that we have similarly tested MRI and radiographs. And then radiographs is superseded by MRI dramatically.
Okay, please go on with the questions because we also need to move on with the timing.
Michael Schirmer from Austria. I have only 2 minor comments. One is, in the STEM we have patients with a diagnosis of axial spondyloarthritis, and Martin just mentioned that patients suspected with axial spondyloarthritis were included.
They were included in the classic study, but then there were, then we had 2 groups, patients who got a diagnosis versus those who did not get a diagnosis, and that served as the basis for the discrimination. So we used really the diagnosed patients.
Okay. And the other one is, as far as I understood, the family history may be important for those patients with HLA-B27 negativity. As a surrogate.
No, we didn't test it here, but in other data that added only, if you know that a patient is HLA-B27 negative, then it's not the family history that's helping, only if you have no information on HLA-B27.
Because I thought about the JIVA studies, you have more possible mutations.
Well, but regarding family history, the majority of positive affected family members have ankylosing spondylitis, so this is number 1. And there are all the genetic studies from Matthew Brown who showed us that basically if ankylosing spondylitis runs in families, they are all B27 positives. They are all B27. So that is closely linked.
Okay, next question.
We
need to keep it, let's say, not very short, but at least precise, because we should be ready in about 12 minutes from now, please.
Yeah.
Miriam de Vries from Sweden. I had a similar point as Mikkel de Goortman, but I still wanted to play the devil's advocate. We all know that everyone in this room becomes more confident when you see sacroiliitis on imaging. And I just wonder, do we really want to include patients in studies with the only HLA-B27 arm without sacroiliitis on imaging?
That will depend completely on the study. So for clinical trials, evaluating new treatment, you may say, no, I don't want that. If you do an epidemiological study, an observational cohort, you could decide, yes, I want.
Yeah, but could it play a less prominent role in our classification table or tree, so that we put it down, that it doesn't play such a prominent role as a primary classification criteria, but that in certain circumstances it can be used in that way?
But in both proposals, it has, after imaging, the highest number of points.
Yeah, there really isn't emphasis per se, because everything is just assigned a number. So in Proposal 2, for the purpose of organization, we have imaging or genetics criteria and then clinical criteria. But you could just as easily put the whole list straight down.
But not in the tree format, then it has an equal place.
Okay, yeah, so it's no secret I'm not a huge fan of it, but...
So, yes, let's move on.
Tony Russell, Canada. Just a comment, I noticed that neither stem has a lower age of onset. Now, juveniles are diagnosed with different criteria, and I don't know about MRI, but when I look at a 19-year-old sacroiliac joints, I find them often quite difficult to interpret. Yeah. Should there not be a lower age limit?
Yeah, this is indeed for adults, so that needs to be specified somewhere. Yes.
Thank you very much. Evin Maruf from Kurdistan, Iraq. So my concern is about Proposal 1. Here we have the sacroiliitis. So living in a region with encountering a lot of cases of brucellosis, sacroiliitis, and Behçet disease sacroiliitis, this term may be general, and many will fulfill this classification criteria. So it's a simple recommendation, just the sacroiliitis to be expa feature in MRI.
Yeah, that's indeed the case, because we have for both proposals the exact same definitions. And it's also here the stem is that you first exclude mimics. So if you have a patient with other causes of sacroiliitis, you should not continue down in either proposal.
So, Philip Hellewell from Leeds. A couple of quick comments. As you might expect, I'm going to comment about axial PSA. I don't think either of these proposals will help us include more patients or classify more patients with axial PSA. We still have the problem with the stem, the age and the back pain, which age is greater in axial PSA, less back pain. We still have the problem with the imaging, because we can have spondylitis without sacroiliitis in axial PSA, and we still have the problem with the B27.